For this upcoming lab, we have a lot that we're going to get through. You are going to be assessing vital signs and learning how to do manual blood pressure. You will be administering a functional mobility and ADL standardized assessments. You will be critiquing and analyzing the scores. You'll be synthesizing all of the information and then really formulating a discharge plan. So in terms of vital signs, you will be using a worksheet during lab. The important points are what does blood pressure look like? Or what does it mean? So your systolic, that is your top number. This measures the pressure of the blood pushing against artery walls when the heart beats. And the diastolic is your bottom number, and this measures the pressure of blood that is pushing against the artery walls while the heart muscles rest between beats. So why is this important for you to know? Blood pressure measures the force of blood exerting against your arterial walls when the heart beats. And really this number, if it's high, it means your heart is working harder than it should. And over time, ultimately, this can damage the heart. And these blood pressure numbers can give you valuable information about how your client is performing. So in your PowerPoint, you do have this guide as well as one for pediatrics to help you understand what are typical norms for blood pressure for a human. Now, heart rate, this is how many times your heart is pumping and the number of times it's needed to deliver blood to the body when it's not exercising. If that number is high, that is called tachycardia. If that number is low, that is called bradycardia. That is your resting heart rate. That is when your heart is at rest, and if it's high or if it's low. And this will also give you valuable information about how the body is functioning. Oxygen saturation, this is how much oxygen the body is getting, and if it's getting adequate oxygen. Normal is 95 to 100. Anything below that could indicate any sort of hypoxic or low oxygen levels, which could be a symptom of something. And if it's very low, this could require medical attention. The caveat is with your clients with chronic obstructive pulmonary disease, they tend to live about 88 to 92% at that number. And over-oxygenation could cause high carbon dioxide levels, also called hypercapnia. And those symptoms could include fatigue, headaches, confusion, dizziness. So those could be medical complications. A client who has COPD, and if they have oxygen is a doctor's order. So you cannot increase or decrease how much supplemental oxygen a client is receiving without a doctor's orders. And you need to be closely monitoring what that oxygenation looks like. So if you have a client who has chronic obstructive pulmonary disease and they are saturated at about, let's say, 85%, which we know is quite low, it is contraindicated for you to increase how much supplemental oxygen they're getting, because you could cause that overload of carbon dioxide, which could then cause symptoms of headache, confusion, dizziness, etc. So some strategies would be cueing the client to take a deep inhale and a deep exhale. It could be a rest. It could be, those are really the two big ones. And then looking at what their vital signs are. Respiratory rate, this is how a client respiration is at a normal, at rest, just general activity level. And if this varies, it could indicate something underlying. Similar to your heart rate, if it's high, it could be tachypnea, where there's an increase respiratory rate where somebody's breathing a little bit heavier, or if it's lower, bradypnea, where there could be respiratory depression. So you really want to find out what the underlying cause is, and that could give you a lot of information about your client. Now, these vital signs are the ones that we're going to be talking about in lab. Pain is also a vital sign. We're going to talk about that on a different day. So, development of the occupational profile, we will talk about this more in depth in class. These are some things to consider as you're developing your occupational profile on your initial eval. Who is your client? These are some considerations and must-dos. Again, we will talk about this more in class. Continuum of healthcare, we will talk about this again when it comes to discharge planning and where your client is when you're creating goals and appropriate lengths of stays and frequency duration of your goals. So, in terms of your evaluation, what are you assessing? We're going to talk about functional mobility. This is not just for physical therapy. However, you do need to know what is appropriate for you to assess. So we absolutely are assessing functional mobility, and it is in that context of functional mobility. We are assessing balance. So when you are assessing somebody, you are looking to document how is their balance at a seated level and at a standing level. At a seated level, you will have dynamic balance and you will have static balance. Those are two very different things. Balance looks very different at a seated level, just sitting at the edge of the bed or sitting in a chair, versus moving out of your base of support or changing your center of gravity. So when you have a client who's sitting, number one, where are they? Are they sitting in supported long sit? Are they sitting in a chair? Are they sitting edge of bed? Are they sitting with arm support? Because those change the dynamics of balance. And is it good? Is it fair? Fair plus, fair minus, poor. Standing, same applies. Are they standing statically? Are they standing statically and holding on to something? Are they doing something dynamic, reaching out of their base of support, doing some ADL functional task, reaching into cabinets? What are they doing? And then what does their balance look like? Is it good? Is it fair? Is it fair plus, fair minus? Is it poor? And how much assistance are you providing to help them maintain their balance? You're being very specific. What position are they in? What are they doing? And how is the balance? Types of transfers. We're going to go extensively into transfers. We're going to talk about types of transfers. What types of assistance are you providing? What kind of cues are you providing? You are always assessing this. You are assessing this both in a functional occupational performance context, and you are also doing this in a more standardized way with a standardized assessment. You are also able to document on functional ambulation. I'm very clear that this is functional ambulation. You are not documenting or writing goals on ambulation. That is for physical therapists to do. For you, functional ambulation is how a person is walking while doing something functional. And that's the difference with what your assessment of functional ambulation is. And everything else applies. What are they doing? How are they doing it? What is the quality of it? How much assistance did you need to provide for them to do this functional task? You are working very closely with the physical therapist to determine if the client is able to do functional ambulation, what type of braces or ambulation devices that they need, and advancing them to the next level. So for example, if you're working with a client who is using a cane or a walker, you are not going to, let me repeat this. You are working with a client who is using a walker, status post hip replacement. You are not making the decision to advance them to a cane independently. You are not doing that. That is the role of the physical therapist. So transfer techniques, we're going to do some hands-on training with this during lab. We're going to talk about proper body mechanics, the principles of positioning your client for safe transfers. We're going to talk about what these guidelines are specifically during lab. This should be familiar from your lab in OTM 525. So if you want to refer back to your lab manual on proper body mechanics. We'll talk about preparing equipment and the client for transfer, from positioning the wheelchair to transitioning from supine to edge of bed if they're in bed, and then different types of transfers. So we will talk about stand pivot transfers. This is literally from sit to stand, and then the client pivots. Using a slide board and the indications for which diagnosis are appropriate for using a slide board. Bent pivot, squat pivot, popover transfers. This is where a client does not achieve a standing position, but they are lifting their bottom up and moving it from one surface to another. Now, with all of these transfers, you are identifying what type of transfer you're doing, what surface they're going to and from. You are documenting the gap, what you needed to do to facilitate this transfer, what they're able to do, and then what you need to do. Dependent transfers, we'll talk more about this during class, but this is very important for you to think about. A dependent transfer requires two people. The client is doing no work. The dependent transfer could be a slide board. Again, having a second set of hands is always highly recommended for safety of you and safety of the client. If you have a client who is dependent with their transfers, it is probably safest for you and for the client to use some sort of mechanical lift. If this is a ceiling lift or a floor lift, this is safest for everybody. You still need a second set of hands with mechanical lift transfers, but this will reduce risk of harm to you and potentially your back. And we'll talk more about that during class. And this is really important if you're working in home health. Also, your client is going home. What are the surfaces within the household that a client might be transferring to? A sofa, a chair, a kitchen table, the bathroom, the different surfaces in the bathroom. These are really important things for you to consider during your evaluation. Car transfer is also a big one. We'll talk more about car and driving in another lecture on another day. But a car transfer, the client has to go home. So they need to be able to, you need to practice with them and problem solve how they are going to get in and out of a vehicle. Now, cars, as we know, there are a lot of different types of cars. So it's important as you develop your occupational profile to discuss, is it a 4-door car? Is it a 2-door car? Is it an SUV? Is it a crossover? Is it low to the ground? Is it high off of the ground? How were they getting into the car before? Did they need to hold on to the handle above the seat to help pull themselves into the car? Did they need to step up into the car? So these are very important questions because this will also help you determine and give education on if they need a different mode of transportation to get home, or if they need to go to outpatient, they need to go to doctor's appointments. Like this will really help them frame discharge planning by talking about the car transfer. So levels of assistance, we'll talk again, we'll refer back to this during class. Independent in your everyday way of living, you are without any assistance from anybody. You are living your best life independent. Mod I, it's the same, except there's some sort of modification to the activity. They don't need any physical assistance from anybody. They're living their best life on the typical everyday day, but it just is in a modified way. So maybe it's a wheelchair, maybe it's a walker, maybe it's a tub bench, a piece of adaptive equipment, but they're living their best life, doing their thing. Supervision, somebody's there just in case. Standby assist, contact guard. I'm within reaching distance in case something happens. Minimal assistance, as soon as my bicep tenses, I'm at min assist, 25% assistance from me. Moderate assistance, 50-50. Maximal assistance, 75% me doing the work. And dependent assist, I'm doing the majority of the work. So we talked about functional ambulation, just some things to consider, and I apologize if this slide is a little bit out of order, but for you to know kind of some basic terminology. Gait, the style of how somebody walks, the cycle time, the duration of completing a step or step two, cadence, the rate, stride length, the distance between two placements of the same foot, and walking base distance between the 2 feet. So if you're reading a physical therapist documentation, that is important information for you to know. Again, I'm sorry, these are a little bit out of order. So some safety strategies to that are must knows and some considerations when you're doing functional ambulation. Know the client's status before you get them up and walking. Do they need some sort of orthotic? We'll talk about orthotics in a second. What are their precautions? Do they have fall precautions? Are they orthostatic, meaning their blood pressure can drop without notice? Are they medically stable? Are they using a walker or a cane with physical therapy? Do they need a wheelchair follow? These are all really important things for you to consider before getting somebody up and walking on your initial eval. You need to use appropriate footwear. Never, ever, 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 the first time you lay eyes on somebody, walk with them without shoes or grippy socks. Make sure you're always monitoring their physiological response. If they are getting up and walking, you could potentially be the first person to get them up and walking, having determined that it's safe based on their status, based on their precautions. You've got a wheelchair follow, you've got a second set of hands, you've brought a walker with you. If you're in acute hospitalization, you might be the first person to get them up and walking. Make sure you're monitoring their physiological response because they could have a blood pressure challenges or have a loss of balance or get fatigued really quickly. Always, always, always use a gait belt. Do not grab somebody's clothes or their arms to help them walk. Think ahead. Plan. Never, ever, ever leave the client unattended. This is 100% of the time, the first time you're meeting somebody, you never leave them unattended. You don't leave them unattended at the edge of the bed. You don't leave them unattended in the bathroom. You don't leave them unattended in standing. And make sure you set your environment up for success. Clear away any potential hazards or obstacles. So we talked about functional ambulation and what that looks like in a kitchen environment, the bathroom, home management, community. So let's talk a little bit about orthotics. So some orthotics that you might be exposed to, an SMO or a supramalleolar orthosis. This is around the foot and ankle. An ankle foot orthosis or an AFO, that is the bottom right of your screen. That is providing a little bit more stability for the ankle up towards the knee. a KAFO knee ankle foot orthosis, which provides more stability up through the hip. And these are determined by the physical therapist, but if the physical therapist is using them, you also need to use them and train your client on how to don and doff them, and that could be part of your evaluation as well. Assistive devices, know your role. These compensate for deficits in balance and strength. They could decrease pain, they could decrease weight bearing, but you need to remember what your role is with the provision of and determining of assistive devices. So you could be using a cane. There's a whole host of different types of canes, a single point cane, a small base quad cane, a large base quad cane. These all have different levels of stability depending on the base. So a single point cane is going to have less stability than a small base quad cane. A small base quad cane is going to have less stability than a large base quad cane. So knowing what those are. Crutches for you, you're teaching protection of the axilla. A client needs to have good upper body strength. You might also see forearm crutches with your clients, so being able to teach them how to do functional mobility and transfers with different types of crutches. There's a whole host of walkers. You might see a walker with 2 wheels on the front. You might see a walker with 4 wheels. You might work with somebody who has a platform walker where their arms are resting on platforms, and knowing why somebody would be using those and being able to assess functional transfers, functional mobility, ADLs, based on what type of assistive device they are using. And then thinking about community mobility. Your client's going home. You're evaluating clients, or you're evaluating clients within the home, and they're going out into the community. So you need to be able to assess how and where they are doing functional mobility within the community. Or outpatient. If you could be working with somebody who is a frequent flyer and they need to go back to work, and you need to think about how they're going to navigate an airport and what kind of education you can provide. So there's a lot of assessment that goes into community mobility. So some other considerations, other skills that are required for community mobility. All right, evaluation of occupational performance. So this is more specifically occupation. This is a comprehensive evaluation, collaborating with the client to determine what he or she or they want and need to support health and participation. This is your clinical assessment of relevant client factors, such as range of motion, strength, sensation, cognition. This can occur prior to your actual observations of ADLs, but the ADLs, IADLs might give you more information. One of the things you want to consider with the evaluation of occupational performance is this is where you're going to see where somebody might have a barrier or where somebody might have a gap. So if you're doing upper body dressing, think top-down approach. I'm assessing upper body dressing, and I note that there's weakness in the right shoulder, and which requires them to need hands-on assistance for threading their right arm through the shirt to pull it up over their head and to pull the shirt down over their body. So now I've identified there is decreased range of motion of the right shoulder, there's decreased muscle power, joint mobility, joint stability, and now I'm going to do that more bottom-up approach where I'm really going to dive in and find out why there is this barrier with occupational performance. There's lots and lots of checklists and standardized assessments to also help you with the evaluation of occupational performance. So as you're doing your assessment of occupational performance, and let's start with ADLs, you are assessing bathing. What position are they performing bathing? Is it edge of bed? Is it seated? Is it supported long sit? Is it supine? Is it seated in a wheelchair? Is it standing sink side? Is it a shower? Is it a standing shower or a seated shower? Is it a seated shower with standing for pericare only? Is it a standing shower with upper extremity stability on a grab bar? Is it, so you can see as I'm doing my evaluation, I'm really assessing what ADL am I assessing, what position are they doing it in, how much help do they need from me, and any cues that I'm providing. As you're doing your evaluation, you also want to consider setup. So somebody is not independent if I need to set up their equipment for them. Somebody is not independent if I need to give them cues for attention to their precautions or general organization or sequencing. So those would be things that you would document in your, as those gaps, those barriers. And then we'll talk about the standardized assessment of section GG. And we just talked about these. Here are those some assessments that you can have for your toolkit. And they're in your, some of these I think are in your Moodle. I don't think they are in your Moodle. Some of these are free to the public, and some of these are assessments that you will learn in other classes, and some of these are assessments that you might learn out in the real world as an OT that require specific and training, specifically the AMPS. So this is, we were just talking about this in terms of cueing and teaching ADLs. So if you need to teach somebody how to perform any part of an ADL that they didn't need help with before, that is, you're providing the intervention, you need to document that they needed whatever type of assistance. So was it physical assistance? Was it guiding? Was it verbal cueing? Did they need to try it a couple of times before they got the hang of using a sock aid, let's say? Did you use chaining? So did you assist the client until the last step is reached, and then they perform that independently? And then the next time they did it, you help them until the second to last part of the task, and then they perform the last two steps independently or with supervision. And then you did half of the task with them, and then they did the rest of the task on their own. So being able to document that type of what type of teaching that you did, what type of assistance that you provided. Home assessment. So if you're working in, it doesn't really matter what location you're working in, but you could be doing a home assessment while they're in the hospital. You could be doing a home assessment at home. You could be doing a home assessment while they're in outpatient. This is collaborative, so you ultimately really will be communicating with your PT counterpart to make sure all parts of the home assessment are being addressed. There are checklists, and this home assessment is also really going to help frame your discharge plan, education provided. So if you have somebody who's going home, you might be making recommendations for, and asking questions about access into the home. Are there any opportunities or possibilities for them to fall based on like poor lighting or rugs or furniture placement? What do they, for independence within the bathroom, would they benefit from a grab bar installation? Modifications to the general environment to improve their overall independence and success and safety at home. The bathroom, that's our wheelhouse. Like that's the most, probably one of the more important parts of the house. But we want to ask them about the setup of their bathroom. Could a walker or wheelchair get in there? Could a piece of adaptive equipment or durable medical equipment get in there? Do they need a handheld shower head? Is the bathroom upstairs or downstairs? Is the bathroom, does it have a sliding door or a shower curtain? Is it a tub or is it a walk-in shower? These are all really important questions to ask, and then providing education and recommendations for discharge. And that is just a quick and dirty overview of what we're going to get into this weekend or for your next lab. And if you have any questions, of course, never hesitate to reach out.